Hi everyone, and in this video I'll be discussing an exciting topic, that is pharmacodynamics. Pharma means drug and dynamics means action. So in this topic we'll be understanding how the drug works, or what we mean by mechanism of action of the drug. Now before attending this video session, I think you would have consumed coffee or tea. Coffee contains caffeine, and why did you consume that? Because caffeine stimulates the brain. So caffeine is a drug and it has produced action, that is CNS stimulation. Now in the previous videos I have discussed pharmacokinetics, where I told paracetamol. So paracetamol is given for fever. What did paracetamol do? Did it go to the brain and tell the brain, dear brain, temperature is high, fever is high, reduce it? So how did paracetamol reduce the fever? So we'll answer all this question in this topic, that is pharmacodynamics. So let us start. So pharma means drug and the dynamics means action. So the meaning of pharmacodynamics is the action of drug, or in simple meaning I can write it as we'll understand mechanism of action of drugs. So we'll understand how the drug works, or in simple meaning pharmacodynamics is also called as what the drug does to body. What the drug does to body is pharmacodynamics. We all know that. But what body does to the drug, that is pharmacokinetics, we dealt in the previous video. So let us understand how the drug works, mechanism of action. Now basically when I talk about drug, so when we give the drug to a patient, the drug can do these things. A drug can stimulate. So stimulation. Drugs can stimulate. Can a drug depress? Yes, the drug can also cause depression. For example, the sleeping tablet, we call it as sedative hypnotics, they can cause CNS depression. Now the drug can replace. The drugs can replace. So replacement. Simple example is type 1 diabetes. What is the problem in type 1 diabetes? There is no insulin. So what we do is we give insulin. So replacement usage is we give the drug as insulin. We replace when there is no insulin. Suppose the patient has hypothyroidism, what we do? We give thyroxine and we call it as levothyroxine. So these are replacement use. Now the drug can also produce cytotoxic effect. Now what do you mean by cytotoxic? It means killing of the cells. Now why you want to kill the cells? Whether you want to kill our cell or somebody's cell. The drugs can kill our own cells, the human cells, own cells, or it can kill microbes. So we have a separate topic where we will discuss the drugs which kill the microbes, and that is called antimicrobials. Antimicrobials. Now where you want to kill your own cells, there are two situations. One, you are killing the cancer cells, or you are decreasing the T cells and B cells in case of immunosuppression. In case of immunosuppression. So these are the places where we want to kill the cells, and the branch is called as chemotherapy. Chemotherapy. So what the drug does to the body, it can stimulate, it can depress, it can replace, it can cause cytotoxic effect. Now certain times drugs can also irritate. Irritation, for example, we have irritants and counter irritants. Suppose you have headache, you will apply the balm. So it will irritate and decreases the pain. So irritation is one more mechanism of action. So once I understand what the drug does to the body, what exactly happens inside? When the drug enters our body, what happens exactly? Let us understand. Now when we give the drug, let me write it as mechanism of action. MOA stands for mechanism of action. There are two ways the drug can work. Number one, the drug can work with the help of receptors. So the drug can work with the help of receptor. Sometimes there is no need of receptor. It can also work by non-receptor mechanisms. So basically there are two mechanisms, non-receptor mechanism and receptor mechanisms. First of all, let us understand what are the non-receptor mechanisms of action. Number one, we have a method called physical method. The drugs can act by physical method. A classical example is certain poisons. So when you are treating poison, we use an universal antidote. Can you take a guess what is it? And that is called activated charcoal. The universal antidote is called activated charcoal. Now why are we giving activated charcoal? Because activated charcoal will absorb the poison. Absorption of poison. So it will absorb the poison. It's a physical method. Don't confuse absorption. It is adsorption. Just the poison sits on that and poison will not get absorbed into the system. So whenever there is poison, we give activated charcoal. The poison sits on that activated charcoal and it is not absorbed into the systemic circulation. So the method is physical method. The next method of drug action is by chemical methods. So they have chemical methods of mechanisms. Classical example we all know, the HCl. So HCl, hydrochloric acid, where do you find it? In stomach. Whenever there is gastritis, the HCl is very much high. So for that we use drugs such as antacids. Example is magnesium hydroxide. And when they combine, you get magnesium chloride with water. So when we have gastritis, we use an antacid. So what is HCl? HCl is an acid and magnesium hydroxide is basic. Now you know that when the acid combines with the base, what is happening is neutralization. So when you observe the example, there is a chemical reaction between the two, and that's why the drugs can act by chemical method also. The next important aspect how the drug works is by this method, and that is by enzyme inhibition. So they can inhibit the enzyme and they can work. The classical example what we discussed in general pharma is paracetamol. Now what did paracetamol do? When we give paracetamol, did it went into the brain and told the brain, dear brain, fever is high, decrease it? Did it send a WhatsApp message? No. So paracetamol entered the brain and inhibited the enzyme called COX. So when it inhibited the enzyme called cyclooxygenase in hypothalamus, so what happened is there is decrease in fever. So the drugs can also act by inhibiting enzyme. The classical example is paracetamol. Coming to the enzyme inhibition, let me write here enzyme inhibition. So enzyme inhibition, there are two types. There are two important types of enzyme inhibition. One is called the competitive enzyme inhibition. Competitive, and one more is called non-competitive enzyme inhibition. So what is the meaning of competitive and non-competitive? Easy. Now let me write the enzyme for you. This is the enzyme. So the green color what I am writing is an enzyme. So for this, the substrate has to bind. So substrate has to bind, and when it binds, you see a response. So you see a reaction, right? Enzyme combining with substrate, you see a reaction. Now what happens is there is a drug. So drug will inhibit the enzyme. The drug also bind to the same site. Remember, if the substrate and drug bind to the same site, we call it as competitive, because both are competing for the same site. Simple. You come to the class, there is only one chair and two of you are competing for the same chair. That is called competitive. What is non-competitive? Let me write the enzyme. This is the enzyme. Enzyme has one more site, and that is the allosteric site. Now the drug what we use to inhibit the enzyme binds to a different site, that is called allosteric site, and the substrate will bind to the normal site. So this is a different site, so we call it as non-competitive enzyme inhibition. Simple meaning. Same site, it is competitive, different site, non-competitive. So when the drug binds to allosteric site, the substrate also binds, but it cannot produce maximal response. Substrate cannot produce maximal response. Let me give a classical example for competitive. Competitive enzyme inhibition, let me give a drug called allopurinol. I think most of you have heard of this drug, allopurinol. It inhibits an enzyme called xanthine oxidase. Xanthine oxidase, and it's an example of competitive enzyme inhibition. Now another classical drug for non-competitive is acetazolamide. The drug is acetazolamide, and it inhibits an enzyme called carbonic anhydrase. It inhibits the enzyme called carbonic anhydrase. Clear? So classical example for competitive is allopurinol, and non-competitive is acetazolamide. Now there is always a correlation between subjects integration. They can ask you what happens to the Vmax and Km if I use allopurinol. Now remember, when there is competition, the Vmax remains same and the Km increases. In non-competitive, what happens is Vmax will decrease, but the Km remains same. So this is what they can ask you, the correlation between the pharmacology and biochemistry, enzyme inhibition. So recently this question was asked, when the patient is given acetazolamide, it inhibits carbonic anhydrase, what happens to Vmax and what happens to Km? Now I'll give a simple trick here. Suppose you take the example of competitive exams. Competitive exams like your NEET PG, next exam, and non-competitive exams are your university exam, your internal exam. Now consider Vmax. Vmax is daily study. Daily study. So consider Vmax as you are studying daily, and consider Km as the topics. Now you tell me, in a competitive exam, will you study daily? Yes, the daily study remains same. You have to study daily so that you get very good rank. Km, topics. Do you think topics will be same? It keeps on increasing. Every day you study, you will get new information. It increases. Non-competitive, think of your university exam when you are in first year, second year, third year. Internal exams. What do you tell? Do you think when you are in first year, second year, what happens to daily study? Will it be same? No. Nobody studies daily except few. What happens to the topics, Km? It remains same because it's non-competitive. For a first year there is only 3 subjects, second year only 3 subjects. So the topics will not increase. But in competition, the number of topics, the number of subject increases. This is just to correlate an example so that you don't forget it. So this is about the enzyme inhibition, very much important, and the integration between biochemistry and pharmacology. So until now I have told you the drugs act by physical, the drug acts by chemical, and the drug acts by enzyme inhibition. Okay, so moving on to the next aspect, how the drug works, we'll be understanding. The drug works by a method called placebo method. So what do you mean by placebo? The meaning of placebo is I shall please you. I shall please. That is the literal meaning of placebo. Now these placebos, how do they work? They work by psychodynamic effect. Psychodynamic effect. Read it again. It's not pharmacodynamic, it's by psychodynamic effect. Now this exists when there is good doctor-patient understanding, or we can call it as trust. So when the patient trusts the doctor, the drug, whatever he gives, will work. Next, the placebos can increase endorphin release in the brain. Endorphins release in brain. And these can be blocked. So these endorphins can be blocked by naloxone. So this is done to confirm whether they are released or not, right? So placebo, the literal meaning is I shall please you. It doesn't work by pharmacodynamics. It works by psychodynamic effect. It will exist only when there is a trust between doctor and the patient. Patient believes the doctor. And they have shown in study that it increases endogenous opioid, that is called endorphins. What is the example for this? The classical example for this is the lactose tablet. So we give a lactose tablet. We use for injections distilled water. And there is a surgery which is example for placebo, and that is called sham surgery. It is called sham surgery. Now, whenever I talk about placebo, I give an example. A doctor is very busy with his practice and he had no time for the family. So one day the wife decided I will take him to a movie. So they went to the movie, they were watching the movie. And somebody was sitting in front row, and they turned back and saw the doctor is sitting. Then the patient told, "Sir, I am having severe headache after seeing the movie, give me something." Then the doctor took something from the pocket and gave it to the patient. You do one thing, you keep it in the mouth, don't swallow. In half an hour, your headache will be gone. Patient did the same thing. After half an hour, patient gave it back and told doctor, my headache gone. Then the wife was curious. She asked, I checked all your pocket, nothing was there, then what did you give? Then he told there was a button which came off my shirt and I gave it to this. So this is just an example how the placebos can work. But don't try to give button to everyone. It's an example, a story. So what happens, many a times we know that patient may not require the drug, but they insist. So then we give the lactose tablet. Sometimes we give the injections. Sometimes there are surgeries which are not required, but patient will get satisfied only if they undergo a surgery. So patient is taken to the OT, he is put an incision and then closed. So the placebos can work there, wonders. Now why do we use placebo? We use placebo when we are doing clinical trials. When we are using placebo, it is mainly in clinical trials. Suppose I discover a new drug. I want to compare with the placebo. Suppose new drug also treats COVID-19 and placebo also treats COVID-19, then what is the use of new drug? So clinical trials, we use placebos. And also we use it in hospitals, the placebo therapies. Remember, placebos will not work every time. There are people who are reactors, but there are people who don't react also. This is one of the mechanism of drug action. There is no drug only, it's mainly the psychodynamic effect. Now, opposite of placebo, we have a concept called nocebo. Nocebo is opposite of placebo. It's opposite of placebo. Meaning, here the patient doesn't believe the doctor. There is no trust. Even the doctor gives the right treatment, patient will not respond. Patient will think that the doctor is not good. I don't trust the doctor. So nocebo is opposite of placebo. Even you give the right drug, patient will not respond. The next mechanism of action, how the drug works, that is by inhibiting transporters. So they inhibit transporters. For example, there are drugs called tricyclic antidepressants. So these drugs inhibit the transporters which transport noradrenaline and serotonin. We have certain drugs called SSRI. SSRI stands for selective serotonin reuptake inhibitor. They inhibit the serotonin transporters. So we'll study them in the later period, don't worry. So drugs can act like this. So I was telling you non-receptor mediated action. Number one, physical method. There is only a physical activity, that is the activity which are called adsorption. Adsorption is not a chemical reaction. And chemical method, there is a chemical reaction. Number 3, enzyme inhibition. And number 4, placebo. And number 5, by inhibiting transport mechanism. So once we have understood the non-receptor mediated actions, let us understand the receptor mediated actions. So the next important aspect what we are going to learn here is receptor mediated action, that is mechanism of action. Now what is a receptor and how does it work? Suppose I give a drug. The drug will bind to a receptor, and after binding to the receptor you will see an action. So the action is also called as response. So you will see a response. So remember, receptor is a macromolecule, and when the drug binds, the receptor will produce the action. So remember, the drug will give a command to the receptor to either increase the response or decrease the response. And that signal from the receptor, there is a mechanism called transducer mechanism. So that is responsible for the last action what we see, that is the response. Now let me give an example of a drug you all know, adrenaline. Adrenaline binds to beta 1, and that is a receptor, and after binding to beta 1, what happens to the heart rate? Heart rate increases. Now when the adrenaline binds to beta 1, it is not an immediate action, there is some signal transduction mechanism. So signal has to be transduced into the penultimate action, that is increase in heart rate. So in the future we'll be studying the receptors and how the signal is transmitted so that you see the response. So let us start and let us understand where the receptors are located. Now let me write, this is the cell membrane. So this is the cell membrane. Now when we give the drug, the drugs can enter into the cytoplasm. They bind to the receptor in the cytoplasm. This is the cytoplasm receptor, and then they enter the nucleus. So they enter the nucleus, and after entering the nucleus you will see the gene transcription. So there is stimulation or inhibition of gene transcription. So what is the product of gene transcription? It is nothing but either you stimulate or inhibit a protein synthesis. So either you stimulate or inhibit a protein synthesis. So the drugs bind to the cytoplasmic receptor, and then they go to the nucleus and they stimulate or inhibit gene transcription. So the stimulator is called co-activators, and the inhibitors are called co-repressors. So the stimulators are called as co-activators and the inhibitors are called co-repressors. Now many a times what happens, certain drugs can directly go to the nucleus and do the same thing. They stimulate or inhibit gene transcription. They can stimulate or inhibit protein synthesis. So that is about the drug. So co-activator are the one which stimulate, co-repressors are the one which inhibit the gene transcription, guys. Now you tell me, which drug can easily cross the cell membrane and enter into the cytoplasm so easily? Is it water soluble or lipid soluble? Obviously the drugs which are lipid soluble. Now what are the hormones which are lipid soluble? That means they are derived from cholesterol. Obviously the corticosteroids, the sex hormones, they can easily cross. So these type of receptors, we call them as nuclear receptor superfamily. These are called as nuclear receptor superfamily receptors. Now these are the slowest acting receptors. Please remember, these are the slowest acting receptor among all the other group of receptors. You take an example, suppose you take an example of testosterone. Testosterone should be slower acting. If it is faster acting, tomorrow morning the beard would have grown this much. No, that will not happen. And person would have grown like this in months, nothing happens. So they are slow acting receptors. Examples for these receptors, nuclear receptors, are the corticosteroids. So in corticosteroids we have two important ones, the mineralocorticoid and glucocorticoids. These are the nuclear receptor superfamily. Then we have one more, and that is the sex hormones. The sex hormones, what are sex hormones? We have is the progesterone, then estrogen, and one more, the male hormone, testosterone. These are sex hormones. Then we have the vitamins like vitamin A and vitamin D. Then thyroxine. Then we have thyroxine and another receptor called PPAR. So PPR stands for peroxisome proliferator activated receptor. So these are the receptors which are called nuclear receptor superfamily: corticosteroids, sex hormones, vitamin A and D, thyroxine and PPR. Now remember, these are the slowest acting receptor and they act through the nucleus. Either they bind to cytoplasm or they can directly go to the nucleus and do this. And that's why they are called as nuclear receptor superfamily. Okay, so until now what we discussed is a receptor, that is nuclear receptor superfamily. So let me draw the cell membrane again. Now certain times the drug may not enter into the nucleus. Now when the drug doesn't enter into the nucleus or into the cytoplasm, they have to act from outside only. Now those drugs which act outside, they are called cell membrane receptor. So these receptors are located on cell membrane. And the examples are ion channel receptor. We have ion channel receptor. Then we have G protein couple receptor. And then transmembrane receptors. So we have transmembrane receptor. So we'll discuss that one by one. So cell membrane receptors are ion channel, G protein couple receptor and transmembrane receptor. We'll go one by one. First we'll start. So the first one is what we mean by the ion channel receptor. These are called ion channel receptors. Now what do you understand by the meaning of ion channel? Let me draw the cell membrane for you. Suppose this is the cell membrane. So on this receptor we have a channel. So this is the channel. Now what happens when a drug binds? When a drug binds to the receptor, this is the place it binds, it opens the channels. Suppose when the drug binds, the channel is closed and it will open. And it opens, the ions move inside. That's why it is called ion channel receptor. So the ions move inside. For example, I'll take an example of the sodium is ion which will enter inside. So when the drug binds, the ions move inside. Please understand, ion channel receptors are the fastest acting receptors. These receptors will work in milliseconds. So they will work in milliseconds. See the beauty of nature. The nature has given this receptor mainly in the fast conducting tissues. For example, here the brain, CNS, heart, muscles. Imagine that muscle receptors are slowest. To pick up a glass of water, it takes 1 day. Imagine that. So they should be quick enough. So there we find these ion channel receptors where you want the fastest conduction. What are the examples for that? So examples for that is a receptor called nicotinic receptor. So nicotinic receptor, when you activate, the ion that enters is sodium ion. Then we have the receptor called glutamate. So glutamate, when you activate, that will also allow the entry of either sodium or a calcium ion inside. The glutamate has three subtypes of receptor. They are also a subtype of glutamate and they are called as NMDA, AMPA and kainate. So when we come to systemic pharmacology, I will be telling this again to you so you will understand it better. Then we have the receptor called GABA A. Now GABA A is known to conduct the chloride, the negative ion. Then we have a receptor called 5-HT3 and we have the receptor called glycine. So these are classical examples of ion channel receptor and they are the fastest acting receptors we know. So let me repeat: nicotinic receptor, glutamate receptor, GABA A, not GABA B. GABA B is GPCR. Then we have 5-HT3 and glycine receptors. So that is about the understanding of ion channel receptor. Once we have understood ion channel receptor, let us understand the next one, and they are called as G protein coupled receptors. These are called as G protein coupled receptor. Now, how do they work? Let me draw a cell membrane for you. Just a minute. So let me draw a cell membrane. So this is the cell membrane where the G protein coupled receptors are present. Now let me draw this. This is a place where the drug binds and it has the bends like the 1, 2, 3, 4, 5, 6, 7. Now since it has 7 bends, G protein coupled receptor is also called as 7 transmembrane receptor. So it is also called as 7 transmembrane receptor. Now if you see that, it looks like a snake. So this is also called as serpentine receptor. And one more name for that is, it is also called as metabotropic receptor. So these are the same name for G protein coupled receptor. Now what happens when the drug binds to the receptor? Suppose the drug binds to the receptor, what happens? Now before I come to that, why it is called G protein coupled receptor? Because in this end there is a G protein which has the attachment of GDP and we have the so we have the G protein with the GDP, we have the alpha subunit, beta subunit, GABA subunit, all are staying as a family. So this is the G protein coupled receptor. Now whenever the drug binds, what happens is there is a conformational change in the receptor, and what happens is the GTP comes to the action. So when the GTP comes to the action, what happens is the G alpha and GTP will be separated. So the next thing what happens is the G alpha GTP becomes separated and the beta gamma becomes separated. They are separate. Now this G alpha has an intrinsic activity that is called GTPase to cut the GTP. So what happens is it releases a phosphate. So it releases the phosphate, and what happens next is this phosphate is utilized to stimulate or inhibit an enzyme, and it can stimulate or inhibit an ion channel. So that is what happens. So what is the role of beta gamma? Beta gamma also will be responsible for doing this job. Either they stimulate or inhibit an ion channel. They will do that. Now once the action is done, now GTPase activity is done, now G alpha is left with only GDP, because you have removed one phosphate. Again what you get is GDP. So again what happens, it will come back to the same place, beta gamma will come back to the same place. Again you have reconstituted that back. So they are back. Again when the drug binds, they will again do the same job. So I will take an example here. So it's like hum saath saath hai, they are all together. So alpha, beta, gamma, they were all friends and they had some GDP money. So when they got excessive money, the alpha got excessive money, what happened? Alpha became separated from the friends. Then it spent the money phosphate, and beta gamma, they cannot stay like that. They were also doing some job. So once alpha lost the money, then it realized the value of friends. So again they came back. The friends joined together and they again came back. So this is simple story so that you don't forget these things. So this is what the G protein couple receptor. I will explain again. So when the drug binds, there is a conformational change in the receptor. Usually what happens, G alpha, beta, gamma and GDP are together. When the receptor is activated, GTP comes to the action. The G alpha GTP will be attached, and alpha has intrinsic GTPase activity. It will cut the GTP and releases phosphate. The release phosphate is utilized to stimulate or inhibit enzyme. It is utilized to stimulate or inhibit ion channel. Beta gamma also will do that. So once the phosphate is lost, G alpha GDP will be separate, beta gamma is separate. So again they come back and reconstitute the receptor. This is what you mean by G protein couple receptors. Now once we understand these things, let us understand there are certain subtypes of G protein couple receptor. Let us study them. Now the G alpha is the one which will determine what subtype we are dealing with. So there are GS, GI and GQ type of receptors mainly. These are the main receptors you need to understand. Let me tell you what is the meaning of GS coupled receptor. Now the meaning of GS coupled receptor, S stands for stimulatory. So when this receptor is activated, it will activate an enzyme called adenyl cyclase. It will activate an enzyme called adenyl cyclase. In the future I will writing as AC. Now what does adenyl cyclase will do? Adenyl cyclase will convert the ATP inside the cell into a second messenger called cyclic AMP. So the role of adenyl cyclase is to convert ATP into cyclic AMP. Now what does cyclic AMP will do? This will activate another protein called protein kinase A. And this protein kinase A, depending on the tissues, it will produce the action. For example, if the tissue is a heart, when you stimulate the GS coupled receptor, you know that in the heart what we mainly have is beta 1 receptor. I am just giving the example. So in the heart, when you activate GS coupled receptor is beta 1, there is increase in heart rate, increase in conduction and increase in force of contraction. So this is what we see. Now the same receptor, if they are in smooth muscle, let me give an example. Smooth muscle, we have beta 2 and beta 2 is also GS. So smooth muscle, it will lead to smooth muscle relaxation. So this is the difference what we see the actions in these receptors. So yes, remember stimulatory. So what does it stimulate? Adenyl cyclase, which will convert the ATP into cyclic AMP. That will activate protein kinase A, and in the heart it increases the heart rate, force of contraction and conduction, smooth muscle relaxation. Now remember, when you order something in Flipkart, the guy will give the delivery, and after giving the delivery he will not stay in our home. He has to terminate. He has to go out. So once the cyclic AMP has given the message, it has to be terminated. The message has to be terminated, and the message is terminated by the enzyme called phosphodiesterase. So PD stands for phosphodiesterase, and this will make this into 5-AMP and the message is terminated. And the cyclic AMP is what we call it as second messenger. So what is cyclic AMP called as? Cyclic AMP is called as the second messenger. This is the second messenger. So what you understand here is by increasing cyclic AMP, you activated a protein called protein kinase A, and we saw that. I told you when I discussed G protein couple receptor, they can activate or inhibit enzyme, but they also can increase the ion channel or inhibit that. So GS can also increase the calcium entry. So they increase the calcium entry inside the cell. Right. So these are the activities of GS coupled receptor. Remember S for stimulatory. Once I understand the GS, let me move on to the next receptor. The next thing what we are going to discuss after GS is GI coupled receptor. The name GI stands for inhibitory. The name GI stands for inhibitory. Now what does it inhibit? It inhibits an enzyme called adenyl cyclase. Now what is the point when you inhibit adenyl cyclase? There is decrease in activation of cyclic AMP and there is decrease in protein kinase C. And I told you the G protein coupled receptor can also stimulate or inhibit an ion channel. So what do? They close calcium channel. They close calcium channel and they open potassium channel. So that is what the GI coupled receptor will do. Once we have understood GI, let us understand another receptor called GQ coupled receptor. Now what happens when the GQ coupled receptor gets activated? Let me draw the cell membrane here. This is the cell membrane. Now when the drug activates this receptor, so 1, 2, 3, 4, 5, 6, 7. So this is the point where we have GQ coupled receptor and the drug binds here. This is the drug. Now what happens when the drug binds? The GQ coupled receptor will activate an enzyme called It will activate an enzyme called phospholipase C. Let me write the full form. It is called as phospholipase C. Now what does phospholipase C will do? There is something called phosphatidyl inositol bis biphosphate. So that is metabolized into two things, that is IP3 and diacylglycerol. So let me repeat again, when you activate GQ, there is activation of an enzyme called phospholipase C, which will metabolize phosphatidyl bisphosphate into IP3 and DAG. Now this IP3 will increase calcium release, and that is from sarcoplasmic reticulum. DAG will activate protein kinase C. Now this calcium will also activate protein kinase C and they will cause protein phosphorylation. Protein phosphorylation. Yes. Now what does calcium do? When there is increase in calcium release, what does calcium do? Calcium combines with calmodulin and that will activate the myosin phosphorylation. So myosin, when it is phosphorylated, myosin and actin combine, and what you see is the smooth muscle contraction. What we see is smooth muscle contraction. Smooth muscle contraction. So this is what the GQ coupled receptors are going to do. I'll repeat again, when you activate the GQ, there is activation of the enzyme called phospholipase C. This was a question asked in one of the recent exam. The activation of phospholipase C. Then it will split PAP2 into IP3 and DAG. DAG will not move into the cytoplasm, only IP3 will move and increase the calcium release, and that combines with calcium and calmodulin. Myosin gets phosphorylated and myosin activate will combine and there is smooth muscle contraction. DAG will activate protein kinase C, and remember cyclic AMP activate protein kinase C, very much important. Now once we understand this GQ coupled receptor, I will give an example of that. The GQ coupled receptor is a receptor called M3. So M3 is present in bronchus. Now can you tell me what happens when you activate M3? Is it bronchodilation or bronchoconstriction? It is bronchoconstriction because there is smooth muscle contraction. So that is about the G protein coupled receptor, also called as Sub-N transmembrane receptor, also called as serpentine receptor or metabotropic receptors. Now, I told you in that example, the second messenger is cyclic AMP, but here the second messengers are right here. The second messengers are IP3 and one more is DAG, diacylglycerol. These are the second messengers. Now, let me write all the second messengers at one place here. IP3DAG, the cyclic AMP, and one more second messenger what we have is cyclic GMP. Apart from that, nitric oxide, calcium, they also act as second messengers. But remember, in IP3DAG pathway, calcium is not a second messenger in that pathway. So IP3, DAG, cyclic AMP, cyclic GMP, nitric oxide, calcium, they are called second messengers. So that is fine. What about cyclic GMP? Now let me explain this concept of cyclic GMP as second messenger. Now we all know that there is adenyl cyclase. Similarly, we have an enzyme called guanyl cyclase. Guanyl cyclase. Now where is the location of this enzyme guanyl cyclase? Where is it located? Suppose this is the cell. There are two types of guanyl cyclase. One is present in the membrane, that is cell membrane, that is called membrane bound guanyl cyclase. Because it is present in cell membrane, that's why it is called membrane bound guanyl cyclase. If it is present inside the cytoplasm, it is called soluble guanyl cyclase. There are two types, membrane bound and soluble guanyl cyclase. Who will activate this? The membrane bound guanyl cyclase is activated by the natriuretic peptide. Can you tell me those examples of natriuretic peptides? They are the brain natriuretic peptide and atrial natriuretic peptide. They activate this one. Then who will activate the soluble guanyl cyclase? And that is done by nitric oxide. Now what happens when you activate the guanyl cyclase? When you activate guanyl cyclase, this will convert GTP into cyclic GMP. This cyclic GMP is the second messenger, and that will activate a protein called protein kinase G. Remember G for protein kinase G. Don't confuse A, there is protein kinase A, protein kinase C, and protein kinase G. Now this is going to cause smooth muscle relaxation. Smooth muscle relaxation. Now this cyclic GMP, I told you the second messenger's action should be terminated, and that is terminated by the enzyme phosphodiesterase into 5-GMP. So this is how the action is terminated. So until now we understood what is G protein coupled receptor, what is the signal transduction method, what we see, what are the second messengers and what do they do, and also we understood the mechanism of the cyclic GMP, who stimulate this, and what is the penultimate action, what we see with that. We are done with the cell membrane receptor, that is nuclear receptor, G protein coupled receptor. The next one is transmembrane receptors. Transmembrane receptor. Now there are two types. The one which has intrinsic tyrosine kinase activity, so one which has intrinsic tyrosine kinase activity and one which acts through the pathway called JAK-STAT pathway. The one which acts through intrinsic tyrosine kinase activity and JAK-STAT pathway. Let us understand the first one, the drugs which act through tyrosine kinase property. To understand that, again I want to take a cell membrane. So this is the cell membrane. Now what happens? There is a receptor here. There is a receptor here. So it has intracellular domain and extracellular domain. This is the extracellular domain and this is the intracellular domain. So in the intracellular domain they have a receptor called tyrosine kinase. And whenever the drug binds, what happens? When the drug binds, There is one more receptor similar to this. There is one more receptor similar to this, and it also has tyrosine kinase. So when the drug binds, what happens? These receptors will come closer. So we call it as receptor dimerization. Receptor dimerization. So what happens? The receptors will come closer. So then what happens next is the tyrosine kinase gets phosphorylated. So this is what we mean by intrinsic tyrosine kinase property. So once it is activated, the intermediate pathways are activated. Intermediate path are activated, and after that what you see is the action of the drugs. So this is what you mean by the intrinsic tyrosine kinase activity. So when the drug binds, the receptor undergo dimerization, they come closer, they activate the tyrosine kinase which is already present there, and the intermediate pathway gets activated and you see the action. Now what are the examples of drugs which act through tyrosine kinase? Tyrosine kinase receptor, what are the drugs which act through this? Examples are, number one, we have insulin. So this is a common asked question in exam. What is the receptor through which insulin works? Tyrosine kinase. Number two, we have a growth factor called insulin-like growth factor. So it is called insulin-like growth factor, and in simple we write it as IGF-1. Again, this is a question asked in your exam. Then we have the growth factors which act through this. For example, vascular endothelial growth factor. Then we have epidermal growth factor. Then we have platelet derived growth factor. So remember, growth factors. Now this vascular endothelial growth factor, epidermal growth factor, platelet derived growth factor, they are important in cancers. They are going to proliferate the cancer cells. So when I take up cancer chemotherapy, I will be telling there are certain drugs which can target this tyrosine kinase. Now by blocking the tyrosine kinase, we can stop the stimulus from these growth factors and we can stop the multiplication of cancer cells. We'll discuss that there. So I'm just giving an introduction here. So remember, it's insulin, insulin-like growth factor, and growth factors like anything ending with growth factors are going to act through tyrosine kinase pathway. Please remember that. Now once we understand the tyrosine kinase, that is this one, let us understand what do you mean by the JAK stat. How does it work? How does it communicate? How does it produce action? Let us go with that. We call it as the JAK stat. Let me write the same receptor here. This is the receptor. Now here also there is, the receptor is like this. It also has extracellular domain, intracellular domain. But here the problem is they don't have intrinsic tyrosine kinase property. So when the drug binds to the receptor, there is one more receptor which is also getting activated, and these receptors come closer. They come closer. Now what happens when they come closer? They don't have intrinsic tyrosine kinase activity. There are certain kinases, they are called JAK. So JAK stands for Janus kinase. So these Janus kinase, they will come and sit on the receptor. So they will come and sit here, and then they get phosphorylated, and that is what is the activation of the receptor. Now when the JAK is activated, there is stimulation of one more, that is STAT. So it stands for signal transduction and activator of transcription. So STAT stands for signal transduction and activator of transcription. Now these STATs are freely moving in the cytoplasm. Again, these STATs will come and attach. So along with this, the STAT will come and attach, and they get phosphorylated. So once they get phosphorylated, they form a bond, and these will get released. So these STAT which are attached and activated, they are phosphorylated, they will enter the nucleus. So they will enter the nucleus, and that will cause, they will enter the nucleus, and that will cause transcription of genes. Okay, so that's the reason why it is called signal transduction and activator of transcription, because at the end of the signal there is transcription of genes, and this is what we mean by JAK-STAT pathway. Very much important how the drugs will work and how the receptor will work. So JAK-STAT pathway. So let me repeat. When the drug binds, these receptors don't have intrinsic tyrosine kinase activity. They come closer. The JAK, which is freely moving, that is called Janus kinase, will come and sit, and it will get phosphorylated. Then the STAT is freely moving, that is called signal transduction and activator of transcription, and that will get phosphorylated, and two STATs will bind, and they enter the nucleus, and they cause transcription of genes. That is how the JAK-STAT pathway works. Okay, sir, we understood, but what drugs are acting through this JAK-STAT pathway is a question. The drugs which act through JAK-STAT pathway, examples are prolactin. One important confusion you will have is growth hormone. Please understand, if they are given growth factor, the answer should be tyrosine kinase. If they are given growth hormone, you should understand it is JAK-STAT. So the growth is the one which will confuse you. Then we have cytokines, and then interleukins. So these act through JAK-STAT pathway. So guys, in this video, I have told you what do you mean by pharmacodynamics. Pharma means drug, dynamics means action. It's nothing but what the drug does to the body. I told you stimulate, depress, cytotoxic, replace. But how the drug works, it is mechanism of action, either non-receptor, that is physical, chemical, placebo, enzyme inhibition, and inhibitory transporter, or by receptor. What is a receptor? It's a macromolecule, the drug binds, and you see a response with that. The receptors may be located in the nucleus or in the cytoplasm. They are called nuclear receptor superfamily, and who can move easily? They are lipid soluble, that is steroids, the sex hormones, vitamin A, vitamin D, thyroxine, and PPR. They are nuclear receptor superfamily. But not all the drug enter the cell membrane, and they have to act on the cell membrane itself. We have ion channel receptor, the fastest acting, G protein coupled receptors, and transmembrane receptor. We have two types in that, tyrosine kinase and JAK-STAT. Now, what are the examples I should remember, sir? You have to remember the examples of JAK-STAT, tyrosine kinase, nuclear receptor superfamily, as well as ion channel receptor. So what about G protein coupled receptor? Apart from that, whatever receptor you see, they are all G protein coupled receptor. So that is the easiest way to remember. Okay, so this is about the introduction of pharmacodynamics. So in the next video, I will be discussing what do you mean by agonist, antagonist, the dose response curve, all these things. Thank you all.